up, all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today's lecture is going to be on pharmacology, topic antibiotics, general information, and classification. So without much ado, here we go. Alright everyone, antibiotics. Basically, these are the drugs that are used for microbe-induced infection treatments. Terminologies wise, we need to take into account broad spectrum, narrow spectrum, bacteriostatic, bactericidal. These terminologies are very frequently used to classify and define the activity of the antibiotic drugs. Broad spectrum means there is a wide range of activity against, say for example, gram-positive, gram-negative, aerobic, anaerobic bacteria, and the opposite, narrow spectrum, which is very specific for a certain type of bacteria, say for example, killing just gram-positives. Bacteriostatic and bactericidal. These are the definitions for nature of the antibiotic. It's the behavior. Bacteriostatic inhibits the bacterial replication but does not kill the organism. It prevents the mitotic activity of the bacteria. Bactericidal, however, will cause death of the organism. It will actually kill the organism. The other terminologies we need to look at are sensitivity and resistance. Sensitive means inducing activity of a certain drug, which means a bacteria that is sensitive to a certain drug will respond in either bacteriostatic or bactericidal way. A resistance means there's suppression of the activity of the certain drug, which means the bacteria that is resistant to that drug will not let the drug cause bacteriostatic or bactericidal effects. These two are very important in describing the behavior of an antibiotic. What about the types of therapies? Antibiotics are drugs that are used in different types of therapies. First one is prophylactic, which means the infection isn't there yet, we just have to prevent it. What about empiric? Empiric is when you start the therapy, when you feel there's a high chance of infection. And what about treatment? We know that there's an identified organism that is causing a specific infection, and therefore we need a specific treatment regimen. So, prophylactic therapy, empiric therapy, and treatment therapy. That is where we use antibiotics in different doses, different durations. Alright, so further into antibiotics. We're going to classify the general antibiotics into these three categories. These three categories are dependent on the mechanism of action. So for example, antibiotics that act on the bacterial cell wall are cell wall types of drugs. Antibiotics that act on the metabolic pathways, so basically it stops the growth of the bacteria. And antibiotics that act on the ribosome and protein synthase, which means these drugs act on the food of the bacteria. It doesn't let them get nutrients. So this page consists entirely of just cell wall bacterial drugs, and they're all bactericidal, which means that penicillins, cephalosporins, carbapenems, monobactames, and vancomycin are all groups of drugs that act on the cell wall and behave by killing the actual bacteria. However, metabolic pathway drugs are mixed action, and so is ribosome protein synthesis. Mixed action, which means some of those drugs may kill the bacteria and some of those drugs may stop the bacterial growth. We'll take a look at these two in the next category. But for now, let's talk about the cell wall classification of the drugs. But let's talk about penicillin. Before we move ahead with penicillin, I actually want to talk about something called as beta-lactam. The chemical construction of the drugs of penicillins are made with beta-lactam rings. But unfortunately, some bacteria in the world have evolved in order for it to create something called as beta-lactamase. Now, beta-lactamase is an enzyme that breaks down the beta-lactam, the ring that makes penicillin. So basically, there are some drugs that break down, this A's right here is the symbol for breaking down. It breaks down the construction of penicillin, making penicillin inactive. So, now that we know what is beta-lactamase, let's move ahead. The first category under penicillin is narrow spectrum beta-lactamase sensitive. which means the drugs under narrow spectrum penicillins are going to become inactive during contact with a bacteria that makes beta-lactamase. So, narrow spectrum, beta-lactamase sensitive penicillin is known as penicillin V or penicillin G. The second category is narrow spectrum, beta-lactamase resistant. Now these are the drugs that we want. We want to use these drugs that are resistant against the bacterial enzyme that breaks down penicillin. So these are the strong ones in the group of penicillins, but they're still narrow spectrum. Keep that in mind. The narrow spectrum beta-lactamase resistant drugs are methicillin, decloxacillin, oxacillin, and cloxacillin. So the cillins, basically. So strong against bacterial evolution, but still narrow spectrum. Third classification under penicillin is extended spectrum, beta-lactamase sensitive. So extended spectrum, very good. It covers a lot of different spectrums of bacteria, but it is sensitive to beta-lactamase, which means it will become inactive in the presence of evolved bacteria. Those drugs are ampicillin and amoxicillin. This is one of the most famous drugs that we use in dentistry. So it covers a lot of different types of bacteria, but it can become inactive in the presence of beta-lactamase enzyme produced by bacteria. So ampicillin, amoxicillin. The fourth subtopic under penicillins is extended spectrum, beta-lactamase resistant. Now this is the strongest penicillin out there. It is beta-lactamase resistant, so strong against bacterial evolution, and extended spectrum, which means it covers so many different types of bacteria. What are they? There's amox, which is the amoxicillin, plus the clavulonate. It's also known as augmentin in North America. It can be taken orally. Another one of those is ampicillin plus sulbactane, also known as unicin in North America. Now you must be wondering what clavulonate and sulbactane are. These two drugs, or chemical compositions to be precise, they are called anti-beta-lactamase, which means they work to prevent the action of beta-lactamase. So basically, in short, we have penicillin that is made with beta-lactame. Then there are some bacteria that produce beta-lactamase. And then we as researchers came up with these chemical compositions which are anti-beta-lactamase. I hope that part is clear so far. The next group is cephalosporins under cell wall antibiotics. So cephalosporins, we have generations. Now why are there generations? Generations of cephalosporins depict their spectrum. So basically, this is gram-positives, mainly gram-positive and gram-negative, and gram-negative only. These drugs are very important to remember. First generation, we have cefazolin given IV, cephalexin given oral. Second generation, we have cefotetin given IV, cefamidol given IV, and cefuroxime given orally. Third generation, we have cefotaxime given IV, cefotrioxone given IV, cefixime given orally, and fourth generation is cefprime given IV, and the fourth generation does not have any oral drugs. I know these names are very confusing and you can mix them up, but these are important to remember, and specifically the oral ones. Awesome. Cephalosporins are done. We're on to the next ones, which is carbapenems. Carbapenems are wide spectrum, beta-lactamase resistant. So, first shot, this group of drugs is like this drug right here. It is one of the strongest drugs under cell wall affecting drugs. Wide spectrum, beta-lactamase resistant. Those are imipenem, meropenem, ertapenem. But keep this in mind. Imipenem is the only carbapenem that needs a side chemical structure, but meropenem and ertapenem are entirely beta-lactamase resistant. It does not need any side chemical structure. Imipenem needs cilastatin, just like amoxicillin needed clavulanate and ampicillin needed sulbactam. Imipenem needs cilastatin, but these two drugs do not need any side chemical structure. They're strong on their own. So these were the carbapenems. Next under cell wall is monobactam. Monobactam is narrow spectrum beta-lactamase resistant. So they're kind of like these ones. Monobactams, narrow spectrum beta-lactamase resistant, and the drug is aztreonam. Aztreonam. And the last group under antibiotic cell wall is vancomycin. Now vancomycin is a very unique drug. It's very strong. It is used under MRSA. What is MRSA? It is defined as methicillin-resistant Staphylococcus aureus. See, a Staphylococcus infection specifically can be treated with a drug called methicillin that we looked at earlier. But what if that Staphylococcus aureus evolved and became resistant to methicillin? Then now we have an infection known as methicillin-resistant Staphylococcus aureus infection. So for its treatment, we use vancomycin, MRSA. We also treat Clostridium difficile. So there could be an overpopulation of a bacteria known as Clostridium difficile, and that's why we can use vancomycin to treat that as well. Vancomycin is very well known for causing a side effect known as the red man syndrome. So it's a very frequently asked question in dentistry and even in AFK. Red man syndrome, vancomycin. It's a side effect of vancomycin. So after a very thorough classification of cell wall, we have two more categories left for today. It is metabolic pathways and then ribosomes and protein synthesis. So let's take a look at the metabolic pathways. They have three groups of drugs. We have quinolones, metronidazole, and sulfonamides. Quinolones are bactericidal, metronidazole also bactericidal, but sulfonamides are bacteriostatic. So this is the first bacteriostatic group that we came across today. So let's break them down one by one. Quinolones will act by inhibiting the DNA gyrase and topoisomerase. Number 4. These two, DNA gyrase and topoisomerase, are very important for the growth, the formation, the structure of the DNA of the bacteria. But quinolones will inhibit that, which means the bacteria will be born mutated or it'll born and die instantly. It kills the actual function of the bacteria and then it kills the bacteria itself. So the drugs under quinolones are ciprofloxacin, norfloxacin, ofloxacin, and levofloxacin. The second group of drugs under metabolic pathway is metronidazole, a very famous drug. And I'll just add a side note here. Metronidazole is not a group of drugs. It is one drug, and it is the drug of choice for a disease called as necrotizing ulcerative gingivitis or periodontitis. Keep that in mind. Gram-negative bacteria in ANUG and ANUP, acute necrotizing ulcerative gingivitis and periodontitis, are treated with metronidazole. Okay, let's move on with the topic. We know it's a bactericidal, but how? Well, it breaks the DNA fragments and it is reduced by transport protein. Whoa, what does that mean? Well, this is what happens. Metronidazole begins to come inside the bacterial cell. It breaks down into pieces and attaches to the DNA. Well, how does it do that? Well, the metronidazole, when it enters into the cell, it gets reduced, which means it turns into a smaller form by something called as transport protein. This transport protein is produced by the bacteria. With this, so this is like a taxi. So metronidazole gets onto the transport protein as a taxi, goes inside the nucleus, goes to the DNA, attaches itself onto the DNA, and then starts breaking the DNA down. It's also known as a suicide drug. That's the mechanism of metronidazole. Pretty cool, huh? Sulfonamides, the bacteriostatic. It inhibits PABA. What is PABA? It is known as para-aminobenzoic acid. In other words, PABA is food for bacteria. It's required for metabolism of bacterial products. See, bacteria need food, right? So they use PABA. PABA gets utilized to convert into folic acid, and folic acid gets eaten by the bacteria, and the bacteria metabolizes and produces toxins to hurt us. Sulfonamides doesn't let them have food. It inhibits PABA. Drugs such as sulfasalazine, then sulfacetamide, then sulfamethoxazole. These drugs act as bacteriostatic. It basically just starves the bacteria. It doesn't let it affect us, but doesn't really kill it. So that was the metabolic pathway. Alright, the last group of antibiotics in the big classification is ribosome and protein synthesis. So antibacterial drugs that affect the ribosome's synthesis are aminoglycosides, macrolides, tetracycline, lincomycin, clindamycin, and chloramphenicol. This is actually a very interesting drug group, so stay with me here. It is a mixed action, which means aminoglycosides are bactericidal, macrolides are bacteriostatic. Tetracycline is also bacteriostatic. Lincomycin, clindamycin, and chloramphenicol, all bacteriostatic, which means the only bactericidal drug in this group of ribosomes is aminoglycosides. Well, how does it kill the bacteria? Well, aminoglycosides, they bind to 30S ribosome subunits, and they cause translation misreading. You know how DNA synthesis, the protein synthesis in the DNA, they have, translocation, translation, replication, and so on. Well, aminoglycosides, they cause misreading in the translation process of it. So it basically mutates the bacteria and kills it. That's how it causes bactericidal action. Well, what drugs come under aminoglycosides? There's gentamicin, amikacin, tobramycin, neomycin, and kanamycin. Now, what about bacteriostatic macrolides? Well, macrolides, they are known to bind to 50S ribosome units. They cause increase in QT prolongation. Now, that's a concept on its own. Let's get to that in a minute. Macrolides, they bind to 50S ribosomes and they prevent the growth of the bacteria, so bacteriostatic. The drugs under macrolides are erythromycin, which is the prototype drug, clarithromycin, and azithromycin. By the way, just a little side pointer here, azithromycin, much better than erythromycin. Keep that in mind. Now let's jump back to the increased QT prolongation. What does that mean? Remember in the cardiovascular system, there was PQRST waves? Well, macrolides, unfortunately, they cause increase in QT prolongation, which means it extends the QT interval. It makes the heart beat irregularly. Can you believe it? Macrolides cause increased QT prolongation leading to arrhythmias. Incredible. And erythromycin, remember the prototype, but the worst of the three macrolides. Now, next is tetracycline. We all have heard about tetracycline and its stain-causing effect, but it's still bacteriostatic. It binds to 30S ribosomes, just like aminoglycosides, but it doesn't kill the bacteria. All it does is that it inhibits collagenase enzyme. That's all. It just prevents the inhibition of collagenase. It is also a very high concentration in the GFR, which means that it is excreted through the kidneys and at a higher concentration than any other drug here, which means, in other words, if a patient has chronic renal failure, then tetracycline would really not be a good choice. Tetracycline will cause toxicity and actually cause further renal damage. That is what the statement means. Tetracycline is further divided into short-acting, intermediate-acting, and long-acting. Short-acting is simple, tetracycline. Intermediate-acting is known as dimenclocycline. And long-acting is known as doxycycline and minocycline. All of these drugs we're going to get very much familiar with when we have the next lectures on antibiotics. Next group of drugs is lincomycin, bacteriostatic, and attaches to 50S ribosome just like macrolides. Same mechanism of action. Clindamycin is also bacteriostatic, but a good feature about it is that it causes a high bone penetration. Now, what does that statement mean? See, we have written statements all over our lectures that are very short, but I verbally explain those concepts. So I'd like you to pay attention here that in this statement, clindamycin is a high bony penetration, which means we know that in dentistry, there are certain infections that are specifically in the bone, like osteomyelitis or perioapical abscess. These are bone lesions, and that's where clindamycin is a superior drug compared to all the other drugs because clindamycin has a better penetration of the bone. That's what this statement means. But remember, it doesn't kill the bacteria, it's a static. And last drug for our classification of antibiotics in dentistry today is chloramphenicol. Now, this is a very interesting drug because even though it's a bacteriostatic drug and binds to 50S ribosomes, it is a very nasty drug. Why do I say that? Because chloramphenicol is known to cause blood issues. It is known to cause bone marrow issues. Think of it this way. This is how I remembered it. Chloramphenicol, when chlorine is poured into a bone, imagine what would happen to the bone. Every cell in the body, RBCs, WBCs, platelets, everything would die. And the production of it in the bone would stop, right? Chlorine is really bad of a chemical. So I hope you remember this way that chloramphenicol causes the reduction in RBC, WBC, platelets as a side effect. Remember again, chlorine in the bone causes death of all the good cells in the bone marrow. By the way, the term used as a side effect of chloramphenicol is known as pancytopenia. Pancytopenia. It means that all the cells in the bone marrow are reduced. Pancytopenia. Chlorampphenicol's side effect. So, I know I had given a lot of different little pointers, but we will always come back to them in the future lectures when we look at each group of drugs separately in more details. I hope you learned something new today so far though. We'll see you in the next lecture. Thank you for watching, you all, and I hope you learned something new today. We're going to be continuing the antibiotics in details in the next upcoming lectures, so stay tuned, hit the like, share, and subscribe button, and make sure to hit the bell icon. See you again.